I am the very first to admit that I am not a morning person, so please bear with me. So I can get this going the right way. As you've seen, the title of my talk is If You Can't Connect the Issues, Think Connective Tissues. And I would love to take credit for that saying. I admit it is not mine. I saw it somewhere a few years ago. I thought it was brilliant, and I have Googled and re-Googled, and I cannot find who to give credit for on that statement. So if nobody else takes credit, maybe I will sign up for it. I do not want to forget to acknowledge and thank so many people for their support and their attendance. So many brilliant physicians, patients, family members. Can't thank you enough for all making the trip out here and just continuing to move forward with care and participation, treatment of Ehlers-Danlos syndrome. Okay, everybody who's here is premature because you've learned that you have Ehlers-Danlos syndrome. So one of the first things I'm sure you get asked is, what is it? When you go home from your diagnosis and announce that you have this disorder, you're tasked with trying to explain to people what it is. Very often people are first stuck explaining it because of its name, and that leads us to a chronology of who it is named after. I mean, it was first indicated, we believe it was first mentioned by Hippocrates when he was referring to Scythian warriors who had lax joints and had trouble pulling back their bows on their arrows on their bows. There was some mention in the 1600s by a Dutch physician who, I believe it was a young Spanish boy, who he discovered and sort of promoted on a circuit of medical discussions because of his dramatically hyperextensible skin. I would hate to mispronounce this, but I think it's Dr. Chernigubov's association was published in 1892, and he was noted for being able to connect hypermobile joints and skin findings. In 1901, Dr. Ehlers or Ehlers, depending on how you want to pronounce it, he published a case history describing distinct disorder, including joints, hyperextensible skin, and bruising. And not long thereafter, Dr. Danlos also published regarding a disorder very similar to what Dr. Ehlers talked about. And then Dr. Parks-Weber suggested it be an eponymously named syndrome, calling it Ehlers-Danlos syndrome. And more recently, Dr. Beighton published officially the Villefranche nosology, which was designed to officially classify the different kinds of Ehlers-Danlos syndromes. But what is it really? I mean, that just tells us a chronology and a name. It's important to realize that Ehlers-Danlos is it's a group of syndromes. I'm referring to the National Institute of Health's FAST facts, which are widely available. They're what the National Institute of Health tries to have down at a sort of patient consumer level to describe different disorders. It is a heritable disorder of connective tissue, and those are importantly chosen words. Heritable means that it is passed from parent to child, and connective tissues are the tissues that are the cellular glue holding the body together. The idea of these disorders, what they do, they change the look, the growth, or the function of connective tissues. Ehlers-Danlos syndrome is not the only connective tissue. There are more than 200 heritable disorders of connective tissue known, and they include not only Ehlers-Danlos syndrome and its multiple types, but also disorders like Marfan syndrome, osteogenesis imperfecta, Loeys-Dietz syndrome, and some other rarer ones, Stickler syndrome, Alport syndrome, Beals syndrome, many, many more. But what is connective tissue? You know, I think that if you don't really understand what connective tissue is, or you don't keep in mind what and where connective tissue is, this is where your doctors get hung up. This is where other people don't really understand what the disorder is. There are only 4 types of tissue that come together to make our bodies. Epithelial tissue we should think of as a barrier. It's a selective barrier. It either keeps things out or lets things through, and it's in specialized arrangements like glands, for example. Muscle tissue has a very specific function. It is cells arranged and cells that have a characteristic that they shorten. Skeletal muscle, smooth muscle, and cardiac muscle all have something in common. It can shorten when needed. Nervous tissue should be thought of as the information highway or superhighway in the body. Nervous tissue has the job of carrying information, carrying it to the brain, carrying it from the brain, and associating information within the brain. So we have brain, spinal cord, and peripheral nerves that make up the nervous system tissue. Connective tissue is very special, though, because it is everywhere all those other tissues are. It is necessary to support, connect, and separate those tissues. All of our organs are made of just those 4 tissues, and connective tissue is in every organ. Additionally, connective tissue separates and fills in the spaces between organs. So away with the knowledge that you have a connective tissue disorder, it's pretty critical to understand that connective tissues are not just in your joints or your skin, as is so commonly perceived by people not familiar with the disorder. Your connective tissue is everywhere. So it helps to know a little bit about the structure of connective tissue to better understand your disorder. I don't intend this to be a very deep biology lesson, and these talks are going to be available online, so you can kind of pour over this in more detail later if it seems like I pass over anything quickly. But the key idea of connective tissue, there are multiple kinds of connective tissues in the body, but all of them have something in common. They're composed of 3 main things: cells, and then something that comes together in what we call the matrix. You have ground substance and fibers that come together. Cells, ground substance, and fibers. The matrix is made of the ground substance and fibers. The ground substance and fibers are secreted or built by the cells that are part of the connective tissue. Ground substance is more like a gel-like fluid, and it contains numerous different molecules that are necessary for the health of the connective tissue. Fibers are generally, we think of the 2 main fibers being collagen and elastin, and each has a slightly different job. Collagen needs to be flexible and supportive. The thick bundles of collagen are what we call collagenous fibers, and the thinner bundles are reticular fibers. Elastin, it's not just flexible, but it's stretchy, and it retains its shape. After it's stretched, it goes back to its original shape. Though we call those elastic fibers that are made of the elastin molecules. There are additional things called microfibrils, and the reason I'm mentioning them here is the microfibrils they tend to be fibrillin containing, and that's our sister disorder. Marfan syndrome is a disorder specifically involving fibrillin. Connective tissue, it comes in more than one flavor. We can speak of dense connective tissue, and I'm going to talk additionally about loose connective tissue and some other kinds of connective tissues. Dense connective tissue, the thing about that makes it different from others is that there are cells, and generally there are more fibers than there is ground substance. And regularly arranged fibers are going to be found in things where you need strength going in one direction, like tendons, ligaments, and where muscles attach to bone called aponeuroses. The irregularly arranged fibers form more like sheets, so they're in tissues that need strength in multiple directions. That's where we find connective tissue in fascia, joint capsules, the deep skin layers, the heart valves, and the digestive tract, among other places. Different fibers are more common in different tissues. Collagen, like I said before, it provides this flexibility or tensile strength, so it's going to be found in different places than something like elastin is. So we might find the collagen fibers in dermis, tendons, ligaments, organ sheaths, but we need elastin in stretchy places like the aorta and the long ligament that travels down our spine to give our spine strength and movement. Loose connective tissue is a little different than dense in that it has much more ground substance than fibers. So there are a few specific names, and I mentioned alveolar loose connective tissue here because it's very important. That is the playground of inflammation. When we think of having inflammation, whether we're injured or we have a condition, that has to take place somewhere, and it pretty much takes place within the connective tissues because that is a place where these fluids can pile up. That's what we call edema. It's also where chemical signaling takes place, and some of those chemical signalers, an example would be mast cells. They live in connective tissue. Also, when our white cells that are tasked with devouring bacteria do their work, it's very often within this alveolar connective tissue. Inflammation can take place in other places, but this is an important concept that some of the places that are most commonly affected by cellulitis and other kinds of itises is going to be within the alveolar connective tissue. Adipose tissue provides reserve fuel as fats, and it also insulates. The reticular connective tissues are things like your lymph nodes, your bone marrow, your spleen that are involved in producing the lymphoid cells. Cartilage is a very special kind of connective tissue, and its cell types that live in the cartilage is chondrocytes and fibroblasts. They make the ground substance and the fibers. There's three different kinds. There's elastic, stretchy cartilage, like in your ear and in your throat with your epiglottis. The hyaline cartilage is the tougher, harder collagens. It's in the ends, the long bones, and the joints, the rib cartilage, for example. And then we get to fibrocartilage areas that are in very high stress, like the discs in between your vertebrae. One thing to realize about cartilage as a tissue, in order for connective tissue to heal after some sort of insult or injury or problem like inflammation, the connective tissue needs to be well vascularized and have a good quantity of cells that can recover by providing more ground substance or fibers if needed. And cartilage is at a distinct disadvantage because it's not very vascular, so it doesn't have a blood supply to help support healing. That's why when you trash your cartilages, you don't really have a great chance of growing them back or healing them. Bone, blood, and lymphatic tissues are very specialized connective tissues. Bone has what we call an osteoid matrix, and it's particularly pertinent. They have predominantly type 1 collagen fibers. Blood and lymphatic tissue are more like a liquid connective tissue, and it's a little bit special because they don't have so much of those fibrous proteins like collagen and elastin. If you think of blood, it's filled with cells. It's got red blood cells, erythrocytes, white blood cells, leukocytes, and platelets that are thrombocytes, and they're in a plasma matrix. So the ground substance that is blood is made of this plasma matrix, and while it doesn't have protein fibers, it has non-fibrous proteins. Immunoglobulins, fibrinogen, albumin, transferrin are good examples. And then you have lymphatic tissue, which is a lot like blood, but they are lymph cells in a lymph matrix with more non-fibrous proteins. So we just covered the main kinds of connective tissues, and I think, I don't mean to bore people with a biology lesson, but I think it should be sinking in that if you have a connective tissue disorder, think of all the potential ways in which your body is affected. And I know that some people come here and they have already learned about some of the non-joint, non-skin systems, but I meet newly diagnosed people all the time who really have been given the distinct impression from their doctors that really Ehlers-Danlos syndrome is a joint problem or a joint and skin problem. And I think it's very important for anybody with this disorder to understand and be able to educate their physicians or their other clinicians that it's more than that. It's a connective tissue disorder. So I think it's important to say a few words about autoimmune connective tissue disorders. They are also referred to as systemic autoimmune diseases, which makes sense because it's an autoimmune disease of something very systemic, your connective tissue, which is all over the place. They're also sometimes referred to as collagen vascular diseases. One of the keys is that in order for something to be an autoimmune disorder, it has to depend on a triad of conditions. It needs to have genetic factors in place that would predispose you to an autoimmune disorder. It requires some sort of environmental trigger that sets things rolling, and then immune dysregulation occurs, and the body starts to attack itself. And in the case of autoimmune connective tissue disorders, we have the body attacking its own connective tissues. So examples of that would include things like lupus and rheumatoid arthritis and scleroderma. Ehlers-Danlos is not in that list. I'm going to mention here a few words about dietary deficiencies and connective tissues, and I think you'll see how this fits in as I speak a little bit. Vitamin C, ascorbic acid, is mandatory. It is required for collagen synthesis. Those of you that were here to see Lara's documentary yesterday and were there for the question and answer session, she specifically mentioned how much she feels she has benefited from the use of vitamin C, and I felt like saying, and here's why. Vitamin C is mandatory to support healthy collagen formation and therefore to help support healthy connective tissue maintenance. I've listed here, and you can look at it a little closer later, some of the foods that are rich in vitamin C, and mention specifically that preserved meats and carbohydrate-rich foods really don't have any vitamin C. The human body cannot make its own vitamin C, so it is a dietary necessity. So we look at a disorder called scurvy as a good example of how a dietary lack of vitamin C affects the connective tissues. Scurvy first became an issue when people did not have access to fresh fruits, fresh vegetables, fresh foods, and had to rely on preserved things that had a long shelf life. This became relevant in the age of discovery when there were sailors and pirates and people out in the middle of the ocean for months at a time. It's interesting to note Vasco da Gama lost, I can't read, 116 of 170 men in the late 1400s to scurvy. And then Magellan lost over 200 of his men in 1520. So scurvy was a big deal until people figured out what to do about it. That's why these sailors were called limeys. They would take their citrus fruits and store them on the ship and be able to have their vitamin C so they could combat scurvy. Now, what is scurvy? The earlier symptoms when you are early on without your vitamin C include malaise. I can't read these tiny words here. Malaise, lethargy, joint pain, spongy gums, discoloration of skin, easy bruising, and poor wound healing. Ring any bells? Late symptoms include tooth loss, halitosis, edema, anemia, hypotension. Thank you. Convulsions and extreme weakness and extreme pain. And the specific bone pain of scurvy is demonstrable on imaging as a certain kind of osteopenia called ground glass osteopenia. Muscle pain, and this is something I only learned when preparing for this talk, the muscle pain of scurvy comes from the fact that without vitamin C you cannot properly produce or maintain carnitine, which is necessary for your muscles to work. Death in scurvy is often a result of fatal vessel rupture. Everybody kind of get why I wanted to bring this up? A few words on dietary deficiencies involving vitamin D. Again, this is very tiny print, but I can tell you without even having to look at this. Vitamin D is something that the human body is able to manufacture from some precursors that you depend upon nutritionally to have, because when sunlight hits your skin is able to convert an inactive form of vitamin D to an active form of vitamin D. Some of our food sources provide vitamin D3, others can provide vitamin D2. It is rich in things like oily fish and fish livers, eggs, cheese, some other sources. But generally, it is difficult for the population to get enough of their necessary vitamin D supply from the diet we are typically seeing people eat. There's a few disorders I want to mention. Rickets it's the lack of mineralization in bone as somebody is developing. It's the classical bone metabolic disorder related to vitamin D of childhood. Osteomalacia is something that many of us have not heard of, even if we've heard of rickets. Adults have already developed. We're not talking about their growing bones lacking minerals. We're talking about their already grown bones having minerals leached from them or not maintained in them. Whereas a child with rickets will have deformities and bone pain and other problems as they're growing. An adult with rickets will also have bone pain and be at risk for fractures, among other things. Osteoporosis is a separate disorder. Instead of talking about the minerals that make the bones hard, you're talking about the actual bone tissue itself. You're losing bone mass. You're losing the amount of tissue that takes up the space where your bones would be. So it's bone thinning. And that is also affected by vitamin D deficiencies and their effects upon parathyroid hormone and calcium interrelationships that allow you to maintain healthy bone. The last mention on the slide is it is known that certain undifferentiated connective tissue disorders early in their course are kind of hard to describe. In the setting of vitamin D deficiency, some of those disorders will actually go on to be well-differentiated, well-classified, very typical connective tissue disorders. So we're seeing a definite connection between lack of vitamin D or problems in vitamin D metabolism and the health of connective tissues, and most often in bone. Vitamin D has many other roles in the human body as well, but I wanted to stress its role in bone here. Another very important mineral, rather than a vitamin, that relates to connective tissues is magnesium. Magnesium is, I think I'm the magnesium queen. I call it the chicken soup electrolyte. It is good for everything. It is needed in so many places in the body, I can't even begin to explain to you. It's important for regulation and synthesis of proteins, and it's mandatory for collagen formation, as well as elastin, proteoglycans, and glycoproteins, which are all very rich in they're found in connective tissue. Magnesium is another dietary nutrient that is kind of hard for people to get through what they eat. Part of that is our Western diet, preserved foods or processed foods. You know, you're needing to look for certain fresh vegetables, fresh meats, nuts. You know, take a closer look at this if you get a chance, or even read up on it yourself. But the World Health Organization is well aware that there is sort of a pandemic magnesium deficiency. They think that in America, 75% of persons in the United States have dietary magnesium intake that falls below the recommended intake. Where does magnesium fit in with connective tissues or bone and muscle? Magnesium deficiency affects bone metabolism. If you don't have magnesium, you are unable to properly process and use your vitamin D to its fullest extent. So I am very happy to hear all the people that have learned how important it is for them to take vitamin D, but what I'm disappointed in is that magnesium is sort of, you know, the forgotten stepsister, that if you don't have adequate vitamin D, you can take all that, adequate magnesium, you can take all that vitamin D you want, and your level may test out wonderfully, but you still may be scratching your head as to why you're experiencing some of these things. Your doctors are thinking, hey, this repletion of vitamin D will help. What is the other point I want to make here? Oh, yes. In magnesium deficiency, because of the way magnesium interrelates with other chemistry in the body, the pH of the bone connective tissue can start to fall, and you can have resultant osteomalacia, just like you can without vitamin C being present to build, without vitamin D being present to build. With a lack of magnesium, you can see bones actually start to demineralize. So here's some important things. The reason I brought those topics up. Ehlers-Danlos syndrome is a heritable disorder of connective tissue. It is not an autoimmune disorder. And I do from time to time have to correct people because they are making the assumption if they have a connective tissue disorder that it is an autoimmune connective tissue disorder. Ehlers-Danlos syndrome itself is not caused from dietary deficiencies. However, there's something called Hickham's dictum that people should realize. Patients can have as many diseases as they damn well please. So there is no reason that you don't have somebody who has Ehlers-Danlos syndrome and has some vague undifferentiated connective tissue condition. We hear all the time of people who have abnormalities in their laboratory testing from a rheumatology panel. They may not have a formally diagnosed autoimmune disorder, but they have problems. And we definitely have people who have Ehlers-Danlos who have nutritional deficiencies, whether it's a chicken, an egg, a correlation, or true, and unrelated. The point is that if you have Ehlers-Danlos and you have some other condition that is likely to affect your connective tissues, you are likely to be more severely affected overall from your Ehlers-Danlos syndrome. So you need to do things. You need to avoid those allergic or autoimmune triggers. You need to address those autoimmune disorders if they are addressable. Healthy diet and exercise cannot be ignored. Nutritional supplements, here is the key. Sometimes they need to be taken what we call enterally. They need to be swallowed. They either go in orally or they could go in by a feeding tube. But what you swallow does not determine entirely your internal nutritional status. It's what you absorb. And some people cannot absorb what they swallow. They cannot process what they swallow for various reasons, too numerous to mention in a short lecture. Those people may need parenteral repletion, IV injections, even some topical ways to absorb some nutrients. So no two zebras have the same stripes. If we step back from just those conditions that affect the connective tissues and look at also comorbid conditions like other separate inherited medical conditions, congenital conditions, prematurity, other disorders that had people form differently during before birth, injuries, acute or chronic injuries, whether we want to blame them on our klutziness or our connective tissues, they affect the body. Affects the diet, nutritional status, exercise, polypharmacy, and varied pharmacogenetics. Those of you who have stopped by or familiarized yourself with the Genelex table or understanding of this now more currently accepted idea that no two people get the same effects from drugs. And people who have Ehlers-Danlos tend to be on more than one drug. So it's hard to sort out what is the drug benefit, what is the drug side effects, and using all these drugs together, and then the built-in differences from person to person and how their body uses their drugs and are affected by those drugs. Then there's factors affecting access to care that I think we have to acknowledge are part of the Ehlers-Danlos syndrome problems. Geographic barriers, where you live, what kind of practitioners are there, financial limitations, insurance barriers, logistical issues. And I count logistical issues when your primary care doctor is a firewall to giving you a referral or even looking for somebody to help you when they don't know what they're doing. Variable motivation and compliance, that's a factor. And people need to take ownership of how motivated they want to be, how much they want to learn about their disorder, how much they want to help themselves. In this picture, if you look closely, the brown zebra is actually a zorse. It's part zebra, part horse. We have a baby zebra up in the corner. We have what's called a leucistic zebra who has stripes but is predominantly white. We have a melanistic zebra who has stripes and spots and is predominantly black. And then within a small group, some variations on that pigmentation. No two zebras have the same stripes. There's some saying, I think, if you've seen a person with Ehlers-Danlos syndrome, then you've seen a person with Ehlers-Danlos syndrome. None of us are the same, and we have to take all of these things into account. So the heterogeneity of the disorder, as well as just the general heterogeneity of humans, means that we have a very broad spectrum of clinical presentations. There are widely variable disease progressions, which you're not talking about Ehlers-Danlos at just one point in time. How many of you feel the same as you did 2 years ago, 10 years ago, and how will you feel 20 years from now? Treatments vary in efficacy. What works great for one person isn't going to work great for everybody. And this has been documented. Expressivity of this disorder is extremely variable. Howard Levy wrote one of the standard papers on the characteristics of this disorder, and that is something that he stresses in his paper. I think of the problem with Ehlers-Danlos in practice being that so many physicians and clinicians can't see the forest for the trees. They lack knowledge of EDS. They have very little direct clinical experience. Some do, but they're the exception rather than the rule. Clinicians very often are focusing on an individual issue like your hypermobility, your cutaneous manifestations, vascular issues, gastrointestinal, autonomic issues, all those things of concern. Many clinicians are entirely unaware that there's a fairly predictable progression of the disorder throughout the phases of life. And I've quoted here Dr. Castori, who has done studies and actually characterized how much people change in some of these phases. So, you know, I look at it, there's a tree you can look very closely at, there's a whole forest that is, you know, looks a certain way at a certain phase, and then you get into the winter and it looks a complete, the doctors have to be able to take this into account, treating you in the present and helping you prevent and protect your body for the future. This is Ronnie Graham's article that Claire Francomano mentioned yesterday on joint hypermobility syndrome that is stressing it's more than just joint hypermobility. The 3 key points he makes are the fact that it does affect the musculoskeletal system, but also the gastrointestinal system with dysmotility, as well as the autonomic system with autonomic dysfunction. And then this is Mario Castori's article, which every one of you should be familiar with as well. It's widely available in full text, and this is the one that I have found the most success with my colleagues, just handing it to them when they find a, you know, and I hand them off a patient that has EDS, and I want to have them have a nice review. So this is a good one to hand to doctors. It has a lot of pictures in it. I particularly like this diagram. It is a schematic representation. It's meant to suggest in the dark gray circle what we would usually define as joint hypermobility syndrome. And if you notice, poking within that circle are individual white triangles that mention things like chronic pain, autonomic dysfunction, gastrointestinal dysfunction, headaches, and a number of other things. The point he's trying to make here is that if we need to really understand how this fits in within the whole of connective tissues and health. What we see most often, unfortunately right now, is that doctors consider joint hypermobility syndrome, or Ehlers-Danlos syndrome, to just be that little tiny circle in the middle. Really, most of them are going to catch the idea that you have Ehlers-Danlos syndrome because they recognize your joint hypermobility. That's what tips them off. But some of them actually refuse to acknowledge EDS or joint hypermobility syndrome as anything other than affecting the joints. That leads to people isolating each of your individual issues and never connecting the dots between them. It often means that multiple physicians are involved and each only see the discrete issue that they are there to take care of. So this is, you know, I know that we're all very fond of the zebra, but my personal preference to characterize this disorder is the elephant. So already know the blind men and the elephant fable? Well, there was very, very wise men that were very experienced in their life, but they'd been very isolated and they'd never been to meet an elephant. So they were taken to meet an elephant. And along the way, each kind of exclaimed their opinion. And we had the one touching the body wall was saying, it's like a great mud wall. The tusk was like a spear. The tail was like a rope. The trunk was like a serpent. And the leg was like, the ear was like a great fan, and the leg was like the trunk of a great palm tree. So they were all very satisfied with themselves. They knew exactly what they were dealing with. They did not come together and put the picture together as an elephant. So how do we connect the dots? How do we do a better job at connecting the dots in this syndrome? If you can't connect the issues, think connective tissues. This is why I gave you all the lesson on what they are, where they are. It's so important to remember that each distinct disorder, each subtype of Ehlers-Danlos syndrome is part of a larger group, and they arise from a defect in the structure, production, or processing of collagen or proteins that interact with collagen. The clinical presentation of any one person who has this disorder is going to arise very naturally. If there's a problem with the connective tissues, all we have to think of is which connective tissues and where are affected, and that you can kind of naturally imagine what's going to be affected. It's also important to note that numerous of the identified EDS subtypes are specifically not characterized by a mutation in the gene encoding collagen. If we look at a table, it may be very hard to see, and you can look at it later. What I've put a square around is the 3 most prevalent kinds of Ehlers-Danlos syndrome: the classic form, hypermobility form, and the vascular forms. Classic is an actual identifiable defect in type 5 collagens, 5A1, and vascular is identified defect in type 3A1 collagens. You'll notice if you look on the table, there are other kinds of defects that may be affecting the same collagens. But the big gap in the table is hypermobility type. There is no known single genetic defect. There's a misunderstanding. Some people will tell you, well, I have hypermobility type, and that means I have a tenascin X problem. That is not the right way to interpret. There were some publications talking about a small number of people who fit the clinical presentation consistent with hypermobility type and did have identifiable disorders in tenascin XB, but that is not to say that everybody who has hypermobility type, that is what is wrong with them. So hypermobility type is a particular challenge because that underlying genetic mechanism has not been discovered. And if you were able to identify a mechanism for hypermobility type, it would better allow you to potentially characterize the physiology of the disorder, aid in the diagnosis, and be able to design targeted treatment interventions. So I want to stress, until that underlying genetic mechanism at play is known, we have to apply our knowledge of connective tissues and the diversity of connective tissues to understand how to connect those dots for hypermobile EDS. So the remainder of my talk is not meant to be a list to pour over and to explain each condition in detail, and it may be better for people to look at this later on. I just want to stress, there are so many extra-articular manifestations of Ehlers-Danlos syndrome. We need to consider all of the manifestations and connect the dots. I am mentioning here some key points about joint laxity. It is considered a capsulo-ligamentous laxity, and the term hypermobility has to do with movement that is in excess along a normal physiologic axis, whereas instability is not synonymous with hypermobility. It is movement in a way it's not meant to move. It's in a non-physiologic axis or direction. People can suffer subluxations, dislocations, sprains, strains, and joints include the temporomandibular joint. People tend to think of that as an oral problem. It really is a joint, just like any other joint in the body, and deserves attention. It's often forgotten by primary care doctors because they think, oh, I don't deal with that, you just have to go to your dentist. So they have to be open-minded as to how this fits in the whole and how it relates to things like headaches. I have lumped together in my list on these last few slides. I've not delineated intentionally between hypermobile types and other types, so some of the things that are mentioned don't apply to every type of EDS. The echinovirus deformity of feet is not, it's more marked in vascular type than it is in the hypermobile type. And some of the problems like scoliosis are much more exaggerated in some of the forms like kyphoscoliotic EDS findings. We can see muscle hypotonia and motor delay in children. We see a number of soft tissue problems, bursitis, tendinitis, synovitis, tenosynovitis, and fasciitis. Skin, okay. A point to be made is that some of us are worse in youth and can look forward to being better when we are older. I think that's an important thing to tell kids because they're learning, they're growing into their bodies, and if you take good care of your body and protect your joints, there is recognized by some of the researchers and clinicians that progressive joint stiffness can actually end up being an advantage. So getting older is not all that bad. Skin and mucosa, another large list. Most people are familiar with the soft skin, stretchy skin, stretch marks. There are some specific findings that I was surprised to learn about. Keratosis pilaris is quite common in people that have Ehlers-Danlos syndrome, the little bumpy, not really acne, not really rash, little sandpapery bumps people can get on their skin. Dry skin or mismatched, some parts of the body will sweat while some parts are dry. The can you lick your nose Gorlins sign is felt to be much more common in the EDS population than in the general population. There's a large number of dental abnormalities, and for this reason I have found that there are a large number of dentists that actually get pretty good at identifying this. There's ocular abnormalities, especially with the high myopia and some of the scleral discolorations. That's a neat little trick if you can tip off some of the clinicians that, on the other hand, it kind of backfires because they'll say, well, you can't have Ehlers-Danlos, you don't have blue sclera. So, it depends on the doctor that I want to emphasize that with. Gastrointestinal system. I lectured last year on this, and I need to make sure my slides are widely available because I could talk for hours on this. It's just crazy how much connective tissue there is in the gastrointestinal system from one end to the other. if you can think of something that can go wrong with the gastrointestinal system, it can probably go wrong with it in Ehlers-Danlos. I think that's a decent way to sum it up. Things I want to stress are people don't think they have heartburn. They may have silent heartburn. They can end up having laryngotracheal reflux that can give them a hoarse voice or apparent recurrent sinus infections. Hernias are common, misshapen, enlarged, and very long bowels, malrotated bowels, bowels that flip into the wrong position in the abdominal cavity are common. It's important to stress that there are not just structural and anatomic findings, but functional physiologic findings. Some of them are well defined by the Rome 3 criteria. And then we have another subject near and dear to my heart, which is bacterial overgrowth or dysbiosis. Nobody leaves my clinic without learning what kefir is. It is a superfood probiotic that will help if you can tolerate dairy, if you can tolerate the milk sugars and milk proteins. It's an excellent source of calcium, vitamin D, proteins. It's a low glycemic index. Some of the recipes have fiber in them, but it has many, many, many beneficial bacteria to help the gut bacterial balance that is in disarray in so many people with EDS and gastrointestinal issues. Cardiovascular system. Most of us are familiar with the cardiovascular findings. We're most familiar with the vascular type and their vascular risks, but we also have many people who learn about their joints and skin and are unaware of the fact that they really should have an echocardiogram with hypermobility type EDS or classic type EDS to look for valvular abnormalities or aortic root dilatation. And then the big topic that I am actually not lumping the cardiovascular system, but will be lumping in the nervous system, is dysautonomia. The nervous system involving the brain, spinal cord, and peripheral nerves, I think of that more of the structural issues, as well as the phenomenon of headaches and pain. We can have intracranial pressure abnormalities, either high or low pressure. We can even have spontaneous cerebrospinal fluid leaks. That's a condition that people need to have on their radar. Dr. Fraser Henderson spoke very eloquently yesterday about a number of the kinds of nervous system deformation that we can get in the central nervous system, so I won't expand a lot here. And then we can find pressure palsies and neuropathies in the peripheral nervous system. The autonomic nervous system, it's a secondary dysautonomia. It's very important to understand that we have not found the disorder in Ehlers-Danlos syndrome to be a primary dysautonomia in which the autonomic nervous system tissue itself is intrinsically or irreparably broken. It may be arguable that because the autonomic nervous systems are wrapped in connective tissue, that is the problem, but the nerve cells themselves are not connective tissue and they are not the broken cells. Dysautonomia can occur either because of structural issues or functional issues. So one way I think of it is if you have a patient that has Chiari malformation and they go get their decompression and they're wondering, why do I still have dysautonomia? The fact is that there are many of us running around who have no identifiable central nervous system deformation and we still have dysautonomia because of the underlying functional dysautonomia that occurs. So this is, we have to tease apart many, many parts of this puzzle to find out how to address dysautonomia, and it's very important to address the structural parts, but you still are left with addressing the functional parts. Generalized versus focal dysautonomia. Some of the functions of individual nerves can be affected by local things happening to them, so we can have vagal nerve dysfunction that affects the autonomic nervous system related to things like herniations and problems in the bowel after certain surgeries if there's a vagal nerve injury. There's lots of things to keep in mind with how our autonomic nervous systems can be negatively affected in Ehlers-Danlos syndrome. I think of these four main types of dysautonomia that can affect us in one or another way or in combination. By far the most predominant type that's been identified and studied in Ehlers-Danlos syndrome is postural orthostatic tachycardia syndrome. The hallmark of that problem is the fast heart rate. The neurocardiogenic syncope is the same systems involved, the neurocardiac systems, neuroendocrine systems, but the hallmark of that problem is the syncope or near syncope. You're going to faint, you feel like you're going to faint, you almost faint. Neurally mediated hypotension, the hallmark of that one, again, the same systems, neurocardiac, neuroendocrine systems, and the end organs, it's hypotension. Can you have all three? Yes. You can have some component of all three. You can feel like you're going to pass out sometimes. You can have tachycardia. You can have tachycardia with hypotension. You can have as many disorders as you damn well please. And then in general, I get people that are very emphatic. I don't have dysautonomia because I don't have POTS, but then they tell me every time they stand up they have a terrible headache and they're nauseous and they feel like they're, you know, whatever the symptoms are. I would bank that under the umbrella idea of orthostatic intolerance. And that's fairly easy to reproduce. So dysautonomia has been around for a long time, even though we haven't had a name for POTS for very long. These were the sort of fainting women, why they had fainting couches when they wrapped up these women in these tight corsets and really affected how well they could maintain their blood pressure and their heart rate and their ability to stand up. But there are many, many names throughout history for POTS, what we now know to be POTS. Immune dysregulation, yet another idea that we could spend hours on, and I'm not going to. Really, it's hard. It's hard if you want to go search PubMed or you want to Google and you want to find what is going on in the immune system in Ehlers-Danlos syndrome. But there is emerging and available medical knowledge. There's widely documented patient experience and patients sharing their experiences on social media regarding the connection between Ehlers-Danlos syndrome and dysregulation of gut-related immunity especially. We see people with food allergies, which are often severe and multiple. We have other forms of inflammatory or autoimmune disorders, gluten intolerance, histamine intolerance, mast cell activation disorder, eosinophilic esophagitis, microcytic colitis, and eosinophilic colitis. Gut-related immune dysfunction is thought to be due in Ehlers-Danlos syndrome to this combination between leaky connective tissue that has a problem, and then you add to that the dysautonomia. You're stuck in rest, or you're stuck in fight or flight rather than rest and digest. So you just don't get a chance to get that gut to get working functionally. And then there's an intestinal dysbiosis which occurs, where once the conveyor belt really stops and is kind of frazzled and broken, the bacteria get way out of balance. And all of that needs to come together to maintain your gut function, including your gut immunity. Once that gut immunity is dysregulated, a vulnerability to inflammatory and autoimmune conditions remote to the gut may be increased. This is a controversial theory among researchers and physicians in the community, but I myself, having experienced patients who improve with attempts to address leaky gut syndrome, I do believe that leaky gut syndrome is what we are looking at in Ehlers-Danlos syndrome, and the idea of gut-related immunity being the trigger or the starting point for many other inflammatory and immune problems within the body in Ehlers-Danlos syndrome. So the last miscellaneous things that I'm going to cover include some things I just don't hear talked about as often but do need mention: pulmonary findings. There's connective tissue in your lungs. So I can't tell you how many people I meet with EDS who are told they have asthma but don't understand why their asthma medicines don't work. And it may be more that you just have floppy airways. You may have impaired gas exchange because of the connective tissue functions, and misshapen airways. Gynecologic issues would deserve a whole other lecture. They can involve just monthly function as well as obstetric issues. There are some possible endocrine abnormalities, and Dr. Posinki started briefly touching yesterday on some of the androgen or testosterone abnormalities and how they may relate to the use of precursors of those hormones that are directed and burnt up in other parts of the body that are trying to cope with Ehlers-Danlos syndrome. There's not a lot of printed, written research on this topic, but I think you will see it growing. Psychiatric issues. How many of you have been told that this is all in your head? Or these problems are all in your head? Or you'd be better off going to a psychiatrist than somebody else taking care of you? There are many proposed correlations between anxiety, panic, depression. There's even an article that was out very recently about OCD being a much higher incidence in Ehlers-Danlos. There's research going on. There are people discussing ADD, ADHD, autism, and autism spectrum disorders in Ehlers-Danlos syndrome. My point is that more research is needed. We are looking at some very objective research that has shown volumetrically abnormal brain regions, including the amygdala and the anterior cingulate and parietal lobes, potentially the influence of dysautonomia with excessive sympathetic nervous system activity, insomnia, or non-restorative sleep, and what effect this has on behavior, mood, and the psyche as a whole. There's also probably an influence of the lack of proprioception. If you can't take sensory input and know where you are in space, it may tend to make you, your mood and your overall psyche be affected. So, my bottom line, Ehlers-Danlos syndrome is more than hypermobility. It's a group of heritable disorders of connective tissue. Each distinct disorder is characterized by clinical symptoms, functional deficits arising from a defect in the structure, production, or processing of collagen or proteins that interact with collagen. And the clinical presentation of any individual type of EDS derives naturally from the specific organs and tissues affected by the defect particular to that type.